Appreciate his willingness to be here in Kansas City and share his expertise. So Dexter.
Thank you very much for having me. Give me a sec to just figure out the mouse orientation. Alrighty. Let me turn this. I'm getting echo. As financial disclosure, so I have tenure. I have no incentive program. I have no relationship financially to anything that I'm going to be describing. But the way the University of Iowa works is that I go to places like here and I teach, and then the University of Iowa is paid for my time. So the University of Iowa, likes it when I'm helping organizations and doing a lot of teaching. The talk is going to be about turnover time, but the focus is not turnover time per se. The goal is to reduce what's called non-value added time. And to some extent, turnover time, you have to clean the operating room. There is value associated with that. But one of the reasons, the whole idea of lean methods, is that you reduce non-value added time. Why is it this study of turnover times? Why are scientific studies have used turnover times for decades? Because we know when the turnover begins and ends. It can be either wheels out to wheels in. That's what we used to use in the historical past when you'd have paper. The inter-rater reliability on wheels out from one patient, wheels into another, is near perfect. People use for the past decade or so sensors off of one patient to sensors on the next patient. Again, there's near perfect inter-rater reliability about when a pulse oximeter is put on a patient. However, there's not inter-rater reliability for when surgery begins, because what does it mean for a wound debridement to begin? There can't be inter-rater reliability. It's not obvious. And if you were to say that if you want to call the value-added time in an operating room to be skin to skin, then are you excluding when you turn the paralyzed patient prone? That doesn't seem to be something which is a value less. So the consequence is when people study surgical times, anesthesia times, and so forth, the mathematics and the behavioral studies have been about turnover time. I'm going to do is sort of these were cartoons that were created by Merck when I gave a presentation involving anesthesia times, but they said that I can change them and use them. And I'm going to go through the cartoon because it summarizes everything that you're going to hear about this morning. The most typical situation in the United States is one surgeon arrives and they do 2 cases and they're 2 different procedures. And there's another surgeon who arrives and does 3 cases of 2 different procedures. And in this scenario, the most typical hospital would have something like an 8-hour day. Now, it could be 8 hours, 7.5 hours, 7 hours, something like that. But that would be basically, this is the typical situation. And if you reduce turnover times or surgical times or anesthesia times, you do not increase productivity. Okay, you do not reduce costs because you don't have, basically your labor is what's called a fixed cost. Everybody's just there. In contrast, what is not that common, but where you can have value is if you have, bear with me for a second, I'm still trying to get used to the mouse here. Okay, is you can have large hospitals oftentimes work later. And if they work later, you have an extended OR schedule. And you plan an extended OR schedule because that increases the efficiency of use of the anesthesia personnel and of the OR nurses, which I'll go through. And on any given day, you don't have overutilized OR time to be reduced. But there is still value in reducing turnover times and surgical times because what you do is you shorten the staff scheduling. You shorten the staff scheduling, people are scheduled to work shorter days. And the consequence is that you have benefit by increasing productivity, but you do it by increasing overtime. So if you have hourly workers, for example, if OR nurses are hourly workers and they're paid overtime, and if you reduce your surgical times, you reduce your anesthesia times, you reduce your turnover times, the way you basically increase productivity and you reduce your costs by increasing overtime. You increase overtime because you reduce the scheduled hours. And that is one of the things in terms of the big picture is when people think in their minds about saying is we want to do is reduce overtime. Basically, this is not the approach you take. The goal is not to reduce overtime, it's to reduce labor costs. By reducing labor costs, you increase productivity. Right? So that is sort of the cartoon version of what you're going to learn about. When you reduce turnover times or surgical times or anesthesia times, what are the topics? One is on any given day, you can focus on the rooms that are expected to have overutilized OR time. And if you reduce overutilized OR time, you've increased efficiency. And that increases productivity. You can still have benefit of increasing productivity on the days in which there is no overutilized time to be reduced. On a long-term basis, you reduce your staffing. And that, epidemiologically, is where there's the greatest value. There are two other benefits of reducing turnover times and surgical times and anesthesia times. And that is to increase the number of cases, which happens. And the other one is behavioral. And that is to reduce the delays, the prolonged turnovers. Okay? But the cover it all takes about an hour and a half. 45 minutes, I'm going to cover the first two topics. If you're interested in the other two topics, this full lecture is online at the website. When you walked in, kind of had the website where it's located. All right, so I'm going to start with talking about how it is that you can increase operative efficiency on the day of surgery by reducing turnover times and therefore reducing overutilized OR time. First, the definition of underutilized OR time. If you plan your staffing till 3 o'clock and you finish at 1, there's 2 hours of underutilized OR time. So if you had perfect knowledge months in advance of exactly when operating would finish, and you knew that there's going to be 2 hours of underutilized time, you would either plan your staff scheduling so people would be scheduled for fewer hours, or you would schedule those people to have training. You schedule the people to give a lecture or something like that. That is underutilized time. Overutilized time would be as if you plan your staff until 3 and you finish at 5. There's 2 hours of overutilized OR time. And if you had perfect knowledge in the future of exactly which rooms would have overutilized time, you plan your staff scheduling so that people are not working late. You would tell them that operating room is going to finish at 5 o'clock. And now, when you have the definition of underutilized time and the definition of overutilized time is defined relative to the staffing that minimizes the inefficiency of use of OR time. Right? So there are 3 simultaneous equations. So just like sort of middle school or high school when you have systems of 2 simultaneous linear equations and you solve simultaneous equations, they are simultaneous equations. So if somebody says, we need to reduce overutilized time, but when you ask is, well, what are you measuring as overutilized time? And they say, well, whatever a committee has said, that is not overutilized time. You could say you want to reduce the hours that we work past the committee time or something, but that's not overutilized time. It is only overutilized time when it is reduced compared to that which maximizes the efficiency of use of OR time. There are 3 simultaneous equations. So I'm going to give an example. So you have full-time employees and the staffing is 7 till 3, but 8 hours, but there's 9 hours of cases. However, what happens is that even though you think there's going to be 9 hours of cases, people work really quickly, and they work quickly. And by reducing the turnover times, although it could be the surgical times or the anesthesia times, and you get done in 8 hours. Right? In that circumstance, have the working quickly increased operating efficiency? And it has. Because as you approach the day of surgery, the cost of an hour of underutilized time becomes negligible relative to the cost of an hour of overutilized time. Okay? And that's because people have already been scheduled months in advance. And so as you approach the day of surgery, the terms involving underutilized time vanish, and you're left only with the hours of overutilized OR time. The cost of an hour of overutilized time is different for housekeepers, OR nurses, society, surgeons, anesthesiologists, nurse anesthetists. It doesn't matter because we're not trying to measure this. We're not benchmarking it. We're making a decision. We're modeling. And therefore, whatever, it's a constant. It's different for different groups. But for each group, the cost is whatever the cost is. And so the consequence is you increase the efficiency of use of OR time on the day of surgery by reducing the hours of overutilized operating time. And that holds for all groups, including from a societal perspective, a hospital perspective, and so forth. It doesn't matter. That's kind of what's the value of the math. So going back to the scenario, you expected to have an hour of overutilized time, but by people working quickly, you don't have an hour of overutilized time because you reduce the turnover times. And therefore, has working quickly resulted in an increase in operating efficiency? Yes, it has. Okay? So working quickly, reducing turnover time, reducing surgical times can increase operating efficiency. Right? In contrast, suppose the staffing that maximizes the efficiency of use of OR time is 7 till 5. If the staffing is 7 till 5, the identical reduction in turnover time now has not increased operating efficiency. It's still just the same turnover time reduction. It's working equally quickly. But if you don't reduce overutilized time, you have an increased efficiency. So it is not that reducing turnover time is a measure of efficiency. It is not that turnover times are a measure of efficiency. It is not that surgical times are a measure of efficiency. All right? If you want to basically increase operating efficiency, you reduce the hours of overutilized OR time. So there are a couple of implications here. One is that on any given day, if you want to have value of how you use your resources, you want to focus on the rooms that have overutilized OR time. The other thing which is important is that the value of turnover time reduction, surgical time reduction, anesthesia time reduction is exquisitely sensitive to the staffing. And so one question, sometimes organizations say, if we're going to benchmark, what is the most important thing to do? It is to know the staffing for each service on each day of the week that maximizes the efficiency of use of OR time. Because unless you do, the residents had a lecture yesterday that went through decision by decision. I went through the anesthesiologists, I went through housekeepers, I went through recovery room, I went through the holding area where the patients show up on the day of surgery. Okay, went through decisions at the control desk. And for every one of those decisions, you cannot make those decisions rationally and consistently if you don't know the staffing for each operating room that maximizes the efficiency of use of OR time. It cannot be done rationally. Okay. Although I'm talking about turnover times and how to value reducing turnover times, the results are identical mathematically for first case starts. So if an operating room has 3 cases and the first case of the day enters 8 minutes late, it's no different than increasing the turnover time by 4 minutes. Right? And the reason that that can be useful is for a number of things. One is that if you financially incentivize anesthesiologists who are medically directing, supervising nurse anesthetists to increase the percentage of first case starts, the consequence is that appropriate decisions to increase the percentage of on-time starts overall results in a reduction in operating efficiency. You need to target the rooms with overutilized time. But if it's more expensive to have overutilized time than underutilized time, less than half the rooms should have overutilized time. Less than half the rooms will have overutilized time. So therefore, how can it be that if you overall try to increase your percentage of on-time starts, because fewer than half the rooms are going to have overutilized time, you will reduce operating room efficiency. You need to focus on the rooms that have overutilized OR time. This is particularly important when you have anesthesiologists who, from a clinical point of view, are supervising nurse anesthetists. Because even if you have the patient wheel into the room on time, if the anesthesiologists are going to be present at critical portions of the anesthetic, and if they're supervising 3 different rooms, right, you will have staggered starts. From a functional point of view, you have staggered starts. So the consequence is, because you will have staggered starts functionally, plan the 3rd start to be the room that is expected to have the most underutilized time. Focus the 1st start to the extent possible on the room that's expected to have overutilized time. And from the studies in Germany, let the surgeons know. One question that people ask is how to be able to change behavior so that progressively you have surgeons filling rooms for the day. Right? One of the ways is to communicate and let the surgeons know your case is going to be the 3rd room that's going to start. We're going to plan your room to start 15 minutes later than the other rooms. Iowa, you can only do 15 minutes or 30 minutes. It's usually about 25 minutes later, but we say it's 15 minutes because that's the option. but let people know so they can still be doing something in their office, in the ward, or something like that. But it also provides total flexibility for scheduling to surgeons, but it also shows that, yes, you are focusing preferentially on surgeons who fill the room for the entire day. Why? Because the longest turnover, on average, is going to be, if you've got more than one surgeon in the room, it's going to be the time from one surgeon to the other surgeon. It's all consistent with the goal of getting value, of increasing efficiency by reducing turnover times. So you are preferentially focusing on operating rooms with overutilized time. And the reason is because your first priority is patient safety, the second priority is to do the cases, and the third is to increase the efficiency of use of OR time, which on the day of surgery means to reduce the hours of overutilized time. Now, this probably seems like very different than what you see and observe, and that is exactly so. People's sense of their fixation on the premise that if we start the day on time, we're going to increase the chance that we finish the day on time, which is not true, is due to a cognitive bias. And the cognitive bias is that people in their minds think of appointments as starting on time or late. So a bus leaves on time or late. A plane leaves on time or late. Most clinic appointments are on time or late. But more than half of surgical cases that aren't the first case of the day start early. Okay? Because if you schedule cases based on the average of historical case duration data, because you have a skewed distribution, more than half the cases will finish early. Right? The cognitive bias. So going through turnover time, so these are data very, very, very old from the University of Iowa's Outpatient Surgery Center. Staffing was planned from 7 till 5. When I say staffing was planned 7 till 5, it means the committee said 7 till 5. A committee said 7 till 5. We use lean methods and we reduce the turnover times, and we've reduced the average number of operating rooms that are running. So did that increase operating efficiency? So if we take a look at the operating allocation, the staffing, 6 rooms till 5, all right, that's what we were told. So that's unchanged. And if you look at then, assuming that that really is the operating allocation, the staffing that maximizes the efficiency of use of OR time, then in that circumstance, the overutilized OR time reduction would be statistically significant, but small, right? So this is about as much of a turnover time reduction as you can get from lean methods. It's small. So there's no practical reduction, increase in the efficiency of use of OR time by the turnover time reduction. Yes, we had an effect, but it's very, very small. The principal effect of reducing the turnover time would have been an increase in the hours of underutilized operating time. And what literally happened was potlucks. Okay, that's really the benefit of what my lean approach basically was. Nurses and nurse anesthetists and some of the anesthesiologists would bring in food in the afternoons and they'd set it out and they would talk and chat. And they may have liked it a lot, but it wasn't lean. The joke was that it was lean, but it wasn't lean because of all the brownies and stuff like that. So we increased underutilized OR time. Hypothetically. Now what's the problem with what I'm saying? The problem with what I'm saying is that by definition, time is only underutilized time when it's compared to the staffing that maximizes the efficiency of use of OR time. And time is only overutilized time when it's compared to the staffing that maximizes the efficiency of use of OR time. So now let's take a look at staffing from 7 till 3. That actually, in that circumstance, if the staffing were 7 till 3, then the turnover time reduction has substantively reduced the hours of overutilized OR time. So which is right? Is the staffing 7 till 5 or 7 to 3? Staffing is not set by a committee. Staffing is whatever it is, right? And we use the formula for minimizing the inefficiency of use of OR time. Now, from a long-term perspective, there are different relative costs of an hour of overutilized time to underutilized time. It can be time and a half, which is like a government set. You can do basically back and forth a standard gamble with people. You get about a 1.75 ratio. The easiest to understand is 2, and the results are negligibly different. These different ratios have an imperceptible effect. it would be the difference of saying 1 milligram of propofol in an adult between these different ratios. So in the relative cost ratio of 2, it is twice as expensive on a long-term basis to finish late than finish early. So if it's twice as expensive to finish late than finish early, which is sort of time and a half and a bit extra for the intangible cost of working late, you plan your staffing so that 2/3 of the rooms finish early and 1/3 finish late. Okay, I'm going to repeat this because you can use this for so many things like in your life. If it's twice as expensive to finish late or arrive late than to arrive early, you want to plan it so that you arrive early, you finish your room early 2/3 of the days, right? So generally speaking, if you've got a hospital and they say something like, I ask, what percentage of your rooms run late? And they say, every room, every day. No, then clearly that doesn't make sense. They're not like finishing, quote, late every single day. It's going to be something like 2/3 of the rooms finish early every day, 60%, 63%, 67%, something like that. That would be typically what you have. If some organizations, 68%, other organizations, 62%. It's in that range. The staffing that minimizes the inefficiency of use of OR time in this outpatient surgery center was 7-3. And so overutilized OR time was relative to 8 hours, and that is why, yes, our lean approach did increase operating efficiency. Right? So here, the moral here is that if your staffing is planned and the cases are scheduled based on maximizing the efficiency of use of OR time, and you have at least 8 hours of cases, then reducing turnover times can increase operating efficiency. Right? So you have to have both things. Not straightforward with the mathematics, but it is not that organizations on their own do this. Right? So we know around the world, when you study it, do organizations just produce staffing that matches that which maximizes the efficiency of use of OR time? They don't. And these are due to different cognitive biases. And there are 2 cognitive biases that play a role. The relative relationship between the 2 is not known. The pull to center bias would be as if you give people the mean workload. So for example, you say orthopedics on Monday has a mean of 30 hours and they have a standard deviation of 10 hours. And you say, which is more important? Is it to have reduce the overutilized time or the underutilized time? They say the overutilized time. And so what do you plan if you have a mean of 30 hours and a standard deviation of 10 hours? How much OR time do you plan for ortho? And they'd say 30 hours. No, you got to use the standard deviation, but people don't do that because humans can't do inverse of probability distributions on their own, right? So even though that is a problem that you could figure out just right here, where would you start? You're not a computer, so unless you pull out a cell phone or something, act like a computer, and you figure out the mathematics, people don't even know where to begin, right? That's issue number 1. The other one is called recency bias, and recency bias would be to say you've got an individual, let's suppose a service is a surgeon. So my wife used to work on Mondays at a hospital. She was essentially the only general thoracic surgeon. So the service was, Elizabeth Dexter. So you'd say, I've calculated the operating allocation, the staffing that maximizes the efficiency of use of OR time using 9 months of data for Elizabeth Dexter on Mondays. All right? And we calculate it should be, for example, till 5 o'clock. And somebody says, but last week she was finished at 3:30. And but what about 2 weeks ago? 3 o'clock. Why don't we wait? All right? Why don't we wait and say, well, wait, I did a time series analysis using 9 months of data. The staffing should be 7 till 5. But if people only fixate on the last few weeks, that's called recency bias. All right? And it's somehow a combination of these 2, and we don't know which it is. But here's why this matters, understanding these are cognitive biases. When you add qualitatively, what do organizations describe for why they don't do operating room management? They say it is a matter of politics. All right, that's one thing you hear. Or organizational culture. We're a slow, lumbering government organization. Or buy-in. We have to have buy-in from all the members of the surgical committee. Or it's personalities. There's Dr. Blah, and, he just wants to do Dr. Blah. Or we just move slowly. And it turns out that you can't determine what is the cause unless you take the decisions of the OR committee and you give it to people, undergrads, who've never been in a hospital, probably other than a patient or never in their lives, you give those decisions to them and see do those decisions they make differ from those of the OR committee? And they don't. It is an issue of human beings don't do math in their heads. All right? It's everybody in an OR committee they're all humans and they're not computers. That's the reason why organizations have trouble with OR management decisions. Right? So that issue number one, if you want to get value from your turnover time reduction, your surgical time reduction, your anesthesia time reduction, you've got to plan the staffing based on maximizing the expected efficiency of use of OR time. Now, the second thing you need to do is you've got to have a long enough workday that the labor isn't essentially a fixed cost. And this turns out to be a useful screening criteria. I worked with a set of hospitals that had basically paid a consulting firm to do lean methods for hip and knee replacement, but they were very disappointed at the end in terms of the lack of value of the initiative because they averaged 5.5 hours of OR time per hour per day for the precise procedures for which they wanted to use lean methods. There's no overutilized time to be reduced. And could it be that these lean methods, that by reducing the turnover times and the anesthesia times, were they going to schedule another case? No, because they would have scheduled the case anyway. They're only working 5.5 hours. Ahmad Bulesh did a survey a long time ago in terms of community anesthesia groups. They averaged 6 hours of anesthesia time per hour a day. And then recently with the American Society of Anesthesiologists Anesthesia Quality Institute data, more than 59% of U.S. facilities complete the majority of their weekly anesthesia workload in the mornings of regular workdays. The mornings of regular workdays. Okay? That's why focusing on whether or not you're going to focus your new drug, your cleaning, your workforce, and so forth on targeting rooms with at least 8 hours of cases. And so if I'm going to do an economic analysis for whatever intervention it is, what I recommend is before doing any calculations, start with the following question. Among the rooms where this is going to be used, how many of them have at least 8 hours of cases? And again, it could be 7.5 hours, it could be 8.5 hours, it varies among the organization. But if there are a lot of operating rooms that have fewer than 8 hours of cases, and intervention is not going to be applied in a targeted fashion, give up. It's not worth it. There's no reason to do an analysis. Okay. Now, the second part to this is that in the cartoon, I started by explaining that the greatest value from an observational point of view of where you get benefit with lean methods for surgical time and anesthesia time and turnover time are for those operating rooms that have more than 8 hours of cases consistently. But if you have consistently more than 8 hours of cases, and because it's twice as expensive to finish late than finish early, right, the consequence is you're going to plan your staffing for long hours. So if you're going to plan your staffing for long hours, oftentimes you're not going to have overutilized time on any given day. But there's still benefit of reducing surgical time, anesthesia times, turnover times, because on a long-term basis, you can now reduce your staffing down to 8 hours, and that increases operating room productivity. So these are made-up numbers, completely made up. Notice I set it up now where at 3 o'clock, do I have a pointer? Yeah. 3 o'clock here it says 4 operating rooms are running on average, and then here 3 o'clock, 2 operating rooms running on average. So before the intervention, if it's twice as expensive to finish late than finish early, if you plan your staffing 7 till 3, you'd have a lot of overutilized OR time, and that would be inefficient. And so the result is you plan your staffing 7 till 5. But now, after the intervention, if you plan your staffing 7 till 5, there would be a lot of underutilized OR time, and that would be inefficient. And so the consequence is now, with the intervention, you would now have reduced your staffing from 7 till 5 to 7 till 3. So by reducing the staffing from 7 till 5 to 7 till 3, the consequence is you've increased productivity. So on the day of surgery, there is not a benefit achieved by reducing the hours of overutilized time. And hopefully the staff scheduling of hourly workers is matched to the staffing, so you're not going to be reducing any overtime. But on a long-term basis, there's benefit by reducing the staffing and therefore reducing the staff scheduling. That's an increase in productivity. So to understand practically when you need to do analysis and when you don't, suppose you know that orthopedics has 3 operating rooms each day for 8 hours, and the mean is 6.8 hours and the standard deviation is 0.8 hours for the cases per operating per day. Right? You can stop there just from knowing the mean and the standard deviation. Because if the mean is 6.8 hours and a standard deviation of 0.8 hours, the operating room allocation, I don't need to do the math to figure out that my operating room allocation is going to be 8 hours or 7.5 hours, whatever is the shortest, duration of staffing that we can do. And the second thing is, if we reduce the anesthesia time, it's not that we're going to close one of those rooms. If we're averaging 6.8 hours of cases in each of those 3 rooms, it's not that we're going to cut down to 2 rooms. So there's no benefit of reducing turnover time or surgical times or anesthesia times from an efficiency perspective or a productivity perspective. In contrast, I don't need to spend time doing mathematics that if it's pediatric otolaryngology and they have 3 rooms each day for 10 hours and they're averaging 11 hours, they have overutilized time in some of the rooms, for starters. But in addition, you may be able, by reducing their anesthesia times and their turnover times, to be able to reduce the staffing from one of the rooms from long day, 10 hours, down to 8 hours. But furthermore, the part of the lecture you're not going to get is this is precisely the situation where you reduce the turnover times and the anesthesia times, and surgeons choose to schedule another case, which is even better. Right? But that is the part which we're not going to have. Okay? So the way it works here is you calculate the current service-specific staffing, you reduce all your turnover times that are longer than a collective maximum value to the maximum, then you recalculate your service-specific staffing, and then you report the reduction in labor costs per units of minutes per 8 hours of staff time. So I'm going to explain what that means. So here, otolaryngology on Monday, pediatric otolaryngology, the 44 minutes says if we reduce the turnover time, we're going to save 44 minutes of regular time. So if in an operating room it were overutilized time, okay, what happens was, this is at a hospital here in Australia. The nurses' staff schedules match the staffing, right? So we were doing calculations for overtime. So if the nurses worked in overtime, if it were 1 minute of overtime, it's 1.5. So if this is it were preference, a lot of overutilized time, the number of minutes of overutilized time reduced is like 44 divided by 1.5. This is the effective number of regular work minutes saved per 8-hour room. So notice the thing to get from this table from the hospital in Australia is the following. The first is you can't say, we need to reduce turnover times. We need to reduce turnover times, because the difference between peds oto and ophthalmology there, okay, that difference is 2,000%. Right? So, in other words, the statement to make is, it's equally important to reduce the anesthesia times or improve the on-time first case of day starts among all the different service and daily week combinations. It's not off by 1%. It is not 10%. It is not 100%. You can consistently rely it's at least 1,000%. Right? You don't waste your time trying to repeat it at other hospitals. It's going to be at least 1,000%. There's no relationship at all. You got to target specific rooms that are expected to have overutilized time, and then rooms of the same surgeon in the room for the day for more than 8 hours, or 7.5 hours, or 8.5 hours, whatever it is. Okay? The other thing to notice is it's not the idea of saying we need to reduce turnover times for ortho, or we need to reduce turnover times for cardiac surgery, or here otolaryngology. It's the individual surgeons. In the oto example, it's not going to have value of reducing the turnover time for the head and neck surgeon. It is, however, for the pediatric otolaryngologist. It's the surgeon. And so when you're thinking about all these things about reducing anesthesia times and surgical times and turnover times, it's about the individual surgeons. That's what it's about. And this normally leads to the next part of the lecture, which is about scheduling another case. Does a surgeon choose to schedule another case? So what are the factors to consider about each service when you're trying to decide in terms of an economic analysis? Is there going to be value reducing turnover times, surgical times, and anesthesia times? From the point of view of the turnover times, wording it that way. First of all, it's the average turnover time. If you have a long average turnover time for a surgeon who operates on a given day of the week, there's going to be a greater chance of benefit from reducing turnover times. Another one is a lot of turnovers, right? If you're doing 6 cases and the average turnover is 40 minutes, you look at the total minutes of turnover that the surgeon has that day. The next one is the hours of cases, including the turnovers each day. If you have 6 cases, all right, and the average turnover is 40 minutes, all right, but the cases themselves are very short, so the result is the hours of cases, including turnovers each day, is brief, is less than 8 hours. There's not going to be value. And the final one is the variability in workload among weeks. If you have a situation where you have an individual surgeon, whenever that individual surgeon comes, they arrive, they do 6 maybe cases, they have long turnovers, and they work for 11, 12, or 13 hours. But sometimes they come on Mondays, and then next week it's Wednesday, and then 2 weeks later it's on a Thursday. It's whenever they come, they work many hours. You can't match your staffing to that. And so variability in the workload of the service on the day of the week results in a reduction in the benefit that you can accrue by reducing turnover times, anesthesia times, and surgical times. And so the consequence is, if you're thinking about benchmarking turnover times or anesthesia times or on-time starts, sorry, it's kind of finicky with the mouse is what's happening. You want to do is, first of all, it is not that there is value in simply measuring the average turnover time for a surgical suite. Next, it's not simply the average turnover time for a service or the anesthesia times. Or same thing for first case a day starts. It is not that there's value in measuring the overall turnover time, all right? And the other one is that when you do these turnover time analyses and first case a day starts analysis, you need to consider the surgeon blocks, because the surgeon blocks determine that's what predicts when a surgeon will show up. So the staffing calculations that I've shown you, that predicts whether anesthesia and nursing have the personnel to care for the surgeon's patients. Surgeon blocks are the way to predict whether an individual surgeon will be there on any given date in the future. Surgeon blocks predict surgeon availability. Staffing calculations predict anesthesia and nursing availability. That's what it's all about in terms of the math. So in conclusion, when you're focusing your turnover time reduction, all these different factors do come into play, and this math basically is well developed. The review article, the one I've been showing you with McIntosh, was published in 2006. All right, so that's more than a decade, was the review article, nonetheless, new science. The additional topics you may be interested in is increasing the number of cases. Another one is this idea of the frustrating prolonged turnovers. This turns out to be extremely important, that a lot of people's perceptions involving turnover times are emotional. They're related to team activity. And so very often, if an organization is really focused on the idea of having the teams perform well, right, what you want to be doing is not focusing on the average turnover, it's reducing the delays, the prolonged turnovers. And that is not the same thing of what to do. Okay. So what I'm going to do is just switch to the website. If you're interested in getting the longer version of the lecture, sorry, one second. Here we go. No. Okay. There we go. Okay, we got a nice picture. Okay. There we go. All right, so this is the Franklin Dexter education. And so the whole version of the lecture here is economics of reducing turnover time. And that also has about increasing the number of cases that surgeons do. In terms of the structure of why these things are in the structure that they are, here I'm going to... Yeah, okay. So let's suppose, for sake of argument, you say, I remember something here about the efficiency of use of OR time or equation. If you remember to go to that, there's a website, and you can find the turnover time lecture. What they have is that every one of these slides have all these references. And the reason is that from the reference, then, you can go to the bibliography, Okay, and you can find the paper. And then from that paper, you can look at the references in the paper. You can go to Google Scholar and look at the citations of the paper. Strum's paper probably has thousands or many, many hundreds of citations. But that's kind of the idea that the lectures provide a way to be able to get into the operating management literature. A lot of the papers are not in PubMed. They're not published in clinical journals. They're published in engineering journals. And that's the reason why this sort of exists. So I showed the residents yesterday that this journal, the one that's 2018, Omega, very well-known industrial engineering, operations research type journal. That's where the basic science is being published nowadays, and it will continue to be published in the engineering journals and in the management science journals. All right, so I was asked to finish at 7:15. It's 7:13 or 7:14, and I'll take questions until I can't take questions. Thank you. Yes.
I thank you very much for bringing the behavioral economics into the realm of the operating room. And I think that the question I have for you is, in a big institution like this, are we better suited to think about continuous ORs in a way in which we move them out, and the ORs which we're going to kind of try to do staffing and modeling so that we absolutely kind of look at the utilization? I think the most important thing, is you hit it on the head, was the utilization of the nursing algorithm versus the anesthesia algorithm. And sometimes in our model, if we're being more efficient and ending earlier, that means that the nurses may actually be sent to home with reduction in pay and or time off against their vacation model.
So I'm trying to take what you're doing and convert it to a question. Can you give me a scenario? I'm not following exactly, just to make sure I answer.
6 ORs, of which we start with 30 ORs, and Melissa would have the exact number, but we start with 30 ORs, and 6 of them are going to be continuous, like emergencies coming in and things like that. The other 24 ORs we can work on the staffing model to try to end them efficiently and work with our utilization numbers. But for those 6 that we have, traumas landing in our trauma bay and things like that, it's just a continuous clock.
Got it. So what I'm going to do is, give me just a few seconds. I think it's going to be here. Okay, so this is the lecture on decision-making. What I clicked here was decision-making on the day of surgery. And it was a resident lecture that I gave yesterday. And basically in it, there are 12 different scenarios. So if you want to send me an email, I can send you a paper we published in 2016 that went through decision after decision after decision on the day of surgery. Okay? And so the lecture basically goes through 12 scenarios, but there are literally an unlimited number. So if you go through decision by decision by decision, and then what you do and you say is, we're going to follow these order priorities, and they are rational. You can prove mathematically that they are sufficient for making the decisions and they're rational. Right? Because they're sufficient for making decisions and they're rational, there is no other set of order priorities to follow for making decisions on the day of surgery. And they are sufficient for making decisions in terms of at the control desk and so forth. So the exercise here is, after people, either the 2016 paper or the lecture, they go through all these different scenarios, and now ask is, wait, how many of these decisions could be made by being down to a certain number of rooms at a certain time of day? And the answer is 0. So the problem with trying to make decisions about being down to a certain number of rooms at a certain time of day is that it applies provided the following assumptions hold. Okay, there are two. First of all, you have to be able to stop surgery in the middle. So if you have, any type of task, like for example, administrators, you could say is secretaries in an administration office, you have those working for short hours and long hours. We're going to be down to a certain number of people at a time a day. Because you can say, my assistant stops working today and she picks up tasks tomorrow. But unless you start stopping the craniotomy in the middle, there is not a way to make decisions to be down to a certain number of rooms at a certain time of day. What happens is, if you make decisions planning your staffing based on maximizing the efficiency of use of OR time, and then you make your decisions based on reducing the hours of overutilized time, being down to a certain number of rooms at a certain time of day is a consequence of those decisions. It's not the cause. So that would be one part to it. So one of the things would be is that because it is rational to plan your staffing based on maximizing the efficiency of use of OR time, it is now that each of the different groups can do their staff scheduling and their staff assignments separately. So in this lecture around scenario 3 and 4, there's this idea of separability. The staffing is something that is calculated from the numbers. It isn't something that's determined or designated by anybody. It is whatever it is. All right. So, for example, anesthesia could plan their staffing based on the OR billing data. The nurses could use the OR information system data, and they're going to calculate the same numbers, almost completely the same numbers for operating cases. And then they can plan their staff scheduling any way they want based upon that. What should be common is the decisions based on the staffing. So you make decisions based on the staffing, and the decisions will be the same because you have the same specification of which of the operating rooms are expected to have overutilized OR time. So I would recommend that you leave it up to the housekeepers and the OR nurses and everybody to do it any way they want. How people are paid is not related to the decisions that increase the efficiency of use of OR time. Compensation isn't here. Now, if you were to say that, well, wait a second, we would like to do is people make decisions based on how they're paid, and we want to incorporate that. Here's the problem with it. These order priorities, this again is the resident lecture that I gave, or parts of it. I'm going to do it from the point of view of picking up somebody at airport because I can see it. Here we go. All right. These order priorities, okay, are sufficient. Patient safety is the top priority. This is, again, it's for picking up somebody at airport. Doing the case is the second priority. Okay. Increasing the efficiency of use of OR time is third. Reducing tardiness from scheduled start times is fourth, and then personal preferences. If you want to do is have the idea of the money, okay, of individuals is a personal preference. Right? So why not, for example, have personal preference as a higher priority? Let me go through why the sequence that you have. First of all, why is increasing the efficiency of use of OR time a lower priority than doing the cases? Because if you never did a single case, the result is you would never have overutilized time and you never have underutilized time. Now, sometimes people say, well, wait a second. It isn't literally that way. Like, there's a balance. You're, like, oversimplifying it. But no, I'm not oversimplifying it because you can't stop surgery in the middle. The idea that it isn't literally that there's a higher priority is based on the idea of task that you can stop the task in the middle. So it is that increasing the efficiency of use of OR time is a lower priority than doing the cases. Right? Why is it that reducing the tardiness from scheduled start times, the waiting of patients, is a lower priority than increasing efficiency? Because you would literally run every operating room 24 hours a day, 7 days a week, 365 days a year. You would literally schedule a gap between each individual surgeon. Right? And the result, though, is that your costs will go way up. Right? So that's why it's rational that it needs to be that reducing patient and surgeon waiting is a lower priority than increasing the efficiency of use of OR time. Why is it that personal preferences, which would include for OR nurses in terms of compensation, why is that a lower priority than tardiness from scheduled start times? The example I gave the residence lecture was the following scenario. Suppose you have an operating room, which was the University of Iowa's outpatient surgery center, and what happened is, and normally the staffing for that surgeon is a room for 8 hours, because the surgeon usually fills the room. But on this day, for whatever reason, a case was canceled or not scheduled, and there's only 2 cases. So there's no way you're going to have overutilized time. You definitely are going to have underutilized time. So what happens is the first case is finished, and now the surgeon's ready to start. The patient is there to begin. And an anesthesiologist said that because the organization puts the preferences of the workers, it's a worker-oriented organization as a high priority, we should all go and have lunch together as a team right now. And we'll come back and we'll finish the case. And if it seems like that has no relationship to how operating rooms run, that's the point. So the personal preferences have to be a lower priority than patient and surgeon waiting. Now, the thing about it is, if you go through the lecture or there's a review article from 2004, these order priorities are sufficient for making these decisions, and they're rational. Because they're sufficient and rational, it is not that you can add in another objective. You can only add another objective by basically doing it consistently. And again, if you want, I can send like mathematical proofs of this. That's the idea. So we can't instill or add an objective based on compensation. So it needs to be sort of like a lower priority. So you can plan your staffing, then everybody can do, each group can do their staff scheduling separately.
As far as like, you know, robots and different surgeons are trying to use, you know, the robots
Equipment.
And it seems like there's just natural delays built into that because you're now following surgeons after surgeons. Do you have any comments on
Yeah.
how that?
So there is a series of stuff. It used to be many, many years ago. It would be, they call them the microscope problems. But it, you know, the thing was now it's robots. Here we go. So the mathematics of what you're describing is how to deal with, sequencing cases. So the idea would be is that imagine you've got one surgeon who is going to do a case with a robot, and then another surgeon who's going to do a case without a robot, then with the robot. And how do you basically do is coordinate between the surgeons. Is that what you're describing? Yeah. So it turns out the following. If you have, you guys have Epic, right? OpTime? Okay. OpTime basically is associate a resource with the case. You want to do, I'd recommend, is create a separate, basically like a separate fake operating room for the robot. And the reason for that is that you want to do is not just pretend that the microscope, that the robot is going to be used for exactly the number of hours scheduled. You need to incorporate the uncertainty in the duration of cases. And it turns out that you can basically just do it using the equivalent of student's t-test. Mean, standard deviation, and sample size. Now, it's not literally student's t-test because you're interested in making a prediction for the next case in each of the rooms. So the next case is with the robot. But we developed this in 2000. The stuff in 2005, what we did was every single surgical case at the University of Iowa, including those that had never been scheduled for the surgeon before. Okay? So we picked pairs of cases which share equipment, and using every single one, no exception, in the 2005 paper, we showed that if we calculate there's an 80% probability that one surgeon will be finished with the robot before when another one is ready, the actual probability is between 78.5% and 81.5%. So these statistical methods really work well. Now, one of the things that makes it easy from an Epic point of view is that these are calculations that are not being done in real time. You can do this the day before or 2 days before, like if you have a huddle or something, you plan out the OR day, sort of what-if scenarios. So the thing is, every few months, you just basically export the data from OpTime, and then you can just do the calculations and whatever, if you have some old laptops. You guys have Windows 7 machines, so we use Dell. So you basically just kind of in an Excel spreadsheet, you have some software that runs, and it does these calculations, and then you can basically say, well, ahead, if this surgeon were to take longer, what is our plan? So the premise here, it's called probabilistic conflict checking. If you want to learn more in terms of probabilistic conflict checking, so this is a case from my course, and I'll get to it, but what we have is exactly this, which is case sequencing over conflicts of equipment. And so people in the course, basically, this is a microscope problem, but if you want to go through that case, you'll kind of get the idea in terms of the implementation. That helps. Or references or hyperlinks or whatever will work. But thank you.
Thank you.